Hello, this is Vivek Dubey. Welcome to Doctor Talks. Here we chat with best doctors about diseases and conditions they treat. In this episode of Doctor Talks, we will talk to Dr. Nilesh Kurwale, a neurosurgeon and epilepsy specialist based out of Pune, India. Have you ever thought what is epilepsy and what are some of the treatment options for epilepsy patients? Today, Dr. Nilesh will help us understand epilepsy and its treatment in a better manner. Welcome, Dr. Nilesh.
Good afternoon, Vivek.
Dr. Nilesh, it would be great to start with a short, brief background about yourself and your journey in epilepsy treatment.
Yeah, so basically, I am a neurosurgeon and I got my degree or residency program from All India Institute of Medical Sciences, New Delhi. After that, I practiced as a general neurosurgeon in Pune, Aditya Birla Memorial Hospital. And during that general neurosurgery practice, I discovered my passion into treatment of epilepsies. So I went back for a fellowship again in epilepsy surgery at All India Institute of Medical Sciences with Dr. Sharat Chandra. And after that, I spent time with Dr. Ashwini Sharan, who is a professor at Jefferson, Philadelphia.
Okay.
After coming back, I started a small-scale epilepsy surgery program at Dinanath Mangeshkar Hospital, Pune, which is a 1200-bedded hospital, not-for-profit organization in Pune. And now, from the staff of 5 people in last 4 years, now we are a big department of 25 people, and we are probably among first 5 programs catering to epilepsy surgeries in India.
Great. And would you be able to define for us that what is epilepsy? There are different perceptions about epilepsy within the society. Just if you can share that, what is some of the basic reasons, or what is epilepsy as such in terms of as a doctor or from your side?
Okay, so epilepsy is a kind of spectrum of disorders. It is a large spectrum, and mainly epilepsy is also in a vernacular language known as mirgi, akdi, khench, jhatka, apasmar, and these are the common terms or used in Indian setting. So basically, what exactly is epilepsy? Epilepsy means most of the people around us are who has seen epilepsy before. They will see a thrashing of limbs and then urination and then frothing of mouth, and this is the quite characteristic symptoms or features of epilepsy. A normal person or lay person understands it, but there are many varieties of way epilepsy manifests, like simple act of spitting on someone, simple act of losing consciousness, simple maybe a 2 or 3 minutes lapses, or a lapse of 15 to 20 odd seconds, just staring and nothing else. So all these things also constitutes epilepsy. So epilepsy just doesn't mean it has to be associated with thrashing of limbs or something, but definitely epilepsy, in most of the epilepsies, the consciousness or the connect of the person with the surrounding is lost, maybe even for a short span of seconds, few seconds to few minutes, and that is why epilepsy is little dangerous. Now there are common
Just sorry to interrupt you, but is it something which occurs from birth, or it can happen later in life?
So basically, epilepsy, there are two main divisions of epilepsy, as we can see. One is like idiopathic, or where we don't know where exactly epilepsy is starting from or what exactly it's coming from, and the other one is symptomatic. So depending on the cause of epilepsy, it can start from the birth or it can start later in life. Like suppose you have some infection during pregnancy, or mother or a kid, he may after birth, he may just can have epilepsy during first few days of life. Or the more common cause is probably low blood sugar after birth can cause to epilepsy. So there are many causes of epilepsy, and depending on which cause it is, you can say whether it can be from birth or acquired later in life. Like in case of tumors you can have after any time during your life, and many tumors present with epilepsy. So epilepsy can be from birth as well as from the later on in your life.
Okay. And uh, is it something which can be, say, where patients can think it will cure by itself, or they need to go for medical help after a certain point of a time, or it can get cured by without medical help also?
Now, interestingly, epilepsy is like a fever. What
Okay.
I normally say, epilepsy is like a fever. So many of the epilepsies, they generally start in early childhood years. And as we understand, in case of fever, most of the fever we have is because of the virus or viral fever. And most of the viral fevers are self-limiting in nature. And even if you don't take a paracetamol or anything, the fever will subside over a period of time because it's a self-limiting viral fever. The same analogy can be given to epilepsies as well, because many a times, at least 50%, if not more, the epilepsies are self-limiting in nature. They start somewhere in your early childhood years, and over a period of 3 to 4 years, they just disappear on their own.
Oh, without any treatment, it can happen. They can disappear at least in 50% of cases.
Yes, they disappear. But the thing is, when you have fever, you just don't let the fever remain. You will always take a paracetamol because you don't
Right.
want a fever, irrespective of whatever the cause of the fever is. You will want to get rid of the fever. The same thing happened with epilepsy also, that you don't want convulsions, you don't want this seizures attack. So whenever epilepsy starts, during the first episode nobody starts a treatment, but after a second episode the doctor will normally start a treatment on on the seizure episodes, because even if this epilepsy may be self-limiting, but you don't want even a single seizure, because that can be detrimental. So that is the logic of starting anti-epileptic treatment for 3 to 4 years. So if you go to any doctor with the epilepsy, they will always say, you take this medicine for 3 to 4 years, and mostly we will take it off this medicine after 3 to 4 years once you don't have any convulsions. So what is the meaning of that? Just like the the paracetamol only controls fever and not its cause. Same thing with epilepsy. Anti-epileptic medicine just controls the seizures. It doesn't affect the source of it or the cause producing epilepsy. So it is like a symptomatic treatment.
But
Like you take
when, say,
paracetamol.
after 3 to 4 years, it gets cured, it means that body cures itself, but till then the medicine helps in preventing seizures. Is that
Yeah,
is
you
that
don't want
understanding
seizures.
correct?
Yes, you don't want seizures during that 3 to 4 year time when it automatically will subside. Just have a simple analogy with the fever. So you don't want fever, even if you know that another 3 years it is going to go away. You don't want it, so you take paracetamol. So paracetamol is not the treatment for the underlying cause. It is actually the treatment for the fever. The same way, anti-epileptic drugs is the treatment for seizures. It's not the treatment for underlying cause. But just because epilepsies are self-limiting in nature, many people believe that anti-epileptic drugs cured their epilepsy.
Okay. And what happens in cases where the anti-epileptic drugs are not able to cure the epilepsy? What should a patient or his caregivers take as the next step?
Now imagine the thing that viral fever doesn't subside after third day. You took paracetamol, but viral fever doesn't subside. What will you do? You will go to a doctor. The doctor will say that probably virus may not be the cause of your illness, fever. And he will investigate with a blood test, urine test, to look for the root cause of fever. And if he finds any bacterial infection, then he will give antibiotics. So antibiotics in case of fever is actually the treatment for a root cause of fever. If the same analogy is extended to the treatment of epilepsy, when your anti-epileptic drug doesn't work, or it is not controlling the seizure, or you, despite having anti-epileptic drugs, your epilepsy continues, it means that probably it is not the type of self-limiting epilepsy. There might be something else. So now here at this juncture, we need to think about the root cause which is producing these seizures. and there might be a number of things which so another now the first 50% of the epilepsies are self-limiting ones, but the other type of epilepsies, like if you grossly classify epilepsies into, so epilepsies, first thing is idiopathic epilepsy. Idiopathic epilepsy means most of the time it is self-limiting in nature. Second, the frequency of idiopathic epilepsy seizures is very low, once in a year or twice in a year. And third, it will respond to only one drug. You start one anti-epileptic drug and patient will be seizure free for another 3-4 years. So these are the characteristics of idiopathic epilepsies or self-limiting epilepsies. However, when you think about when your drugs doesn't control your epilepsy, meaning the chances that this epilepsy might be of the other type, that is remote symptomatic epilepsy or substrate positive epilepsy, what in a layman's term it can be called as, meaning there is some cause or structural abnormality present in your brain which is actually causing short circuits and giving rise to this kind of epilepsy. So this epilepsy, characteristic of these epilepsies are, it will not be responding to drug. It will not respond to drug. Second, the frequency of the seizures will be high. And third, despite adding 2 or 3 anti-epileptics, it will not subside. And fourth, as there is a structural cause or a root cause identified in such epilepsies, unless you address the root cause, you are not going to get rid of this epilepsy and this will continue lifelong. So these are the things which need to be understood as a patient, that which type of epilepsy you might be looking at.
Okay, that was really helpful, Dr. Nilesh. And if the epilepsy is of the second kind, which is not self-healing, how should a patient plan his or her treatment?
Now let us go from the start. So whenever you have a first episode of seizure, so you go to the doctor. So on the first episode of seizure, doctor generally do not start any treatment because it can be because of anything. So the convention is not to start any treatment. But if you have a second episode and then the neurologist or a physician get the EEG done, electroencephalogram done, to confirm that you have epilepsy. Once you are diagnosed to have epilepsy, then the most appropriate drug, considering your clinical symptoms and findings in the EEG, will be started generally by a neurologist or a pediatric neurologist. Both of these doctors are specialized in the treatment of medical epilepsy. So once you are diagnosed, it is their job, neurologist and a pediatric neurologist, to diagnose epilepsy and to start the appropriate medical treatment. Now, once you are started on a medical treatment, the 50% chance that probably it might be a self-limiting epilepsy and it will be just controlled. But if it doesn't happen and you throw seizure during the time you are already on the drug treatment, then in that instance, the second drug is introduced, or the drug is changed to the other drug, or a second drug is introduced. So you will be either on a polytherapy, meaning 2 drugs, or on a second drug, next drug. So if these 2 drugs fail to control your seizures, this happens in 65% of the time, you will be controlled on drugs. But if you fail to respond to these 2 drugs, there is a very high chance that there has to be some structural abnormality in the brain. And this thing we call drug resistant, meaning 2 drugs failed, meaning the chances of third drug, whatever you add, henceforth, third, fourth, fifth, the chances of your epilepsy getting controlled is almost less than 2%. And this has been proven beyond doubt. So here the concept or a nomenclature of drug resistant epilepsy comes into picture, meaning you fail to respond or your seizures do not stop even after putting 2 appropriate drugs in appropriate doses, and you are also taking it religiously without any compliance issues, and you have an acceptable side effect profile. If all these things, all these criteria are fulfilled and still you are having seizures, then you are a candidate of drug resistant epilepsy seizures or drug resistant epilepsy. So once the diagnosis of drug resistant epilepsy is established, then the protocol for treatment differs. Now here you start looking for that structural abnormality, because now you are beyond doubt, you are convinced that you are not a self-limiting epilepsy because you are drug resistant one. So
Right.
here at this juncture, you will start looking at the structural abnormality that is creating this kind of epilepsy in your this kind of seizures in you. So then, so there are protocols. The first thing here would be the doctor will admit you for something called as video EEG.
All right.
What is video EEG? In routine EEG, the first doctor who has acquired your routine EEG, it is just 15 minutes EEG to diagnose on a gross scale. Here, in a video EEG, you are admitted for 3 to 4 days in a hospital where this facility is there, and you will be put on a EEG for all these days. 4 days you will be under.
Sorry,
under
Dr. Nilesh,
Yeah.
just to interpret, and this is because India being a very vast country with healthcare facilities and their capabilities varies from state to state, city to city. As a patient in such a scenario, how should one decide that whom to go meet and which hospital to kind of get the treatment started with? Because what should one look for in a hospital for this kind of pre-evaluation you are mentioning?
So this kind of pre-evaluation is limited to very few hospitals in India, and that's an unfortunate story. But if you inquire about the hospital or a nearest hospital with a video EEG facility to your treating neurologist, he might be able to guide you. But if you ask me, there are 5 or 6 big centers across India, including Dinanath Mangeshkar Hospital, Pune, All India Institute of Medical Sciences, New Delhi, then Sri Chitra Thirunal Institutes in Trivandrum, Amruta Institute in Kochi, and there is, I think, Nizam's Institute in Hyderabad. So basically, Dinanath Mangeshkar Hospital is the only not-for-profit hospital apart from the central institutes which have this kind of large-scale facility for video EEG recording. So,
okay, so for a common person, one thing is to look for a hospital with a video EEG facility, right?
Yeah. So yeah, the treating neurologist should be able to guide you to a video EEG hospital with a video EEG facility. So let us understand what video EEG means. So, and why should we get video EEG done? So once you are in a drug-resistant epilepsy, in video EEG you will be admitted for 3 to 4 days. Your EEG will be put, and you will be under a continuous monitoring of a video camera all 24 hours. 24/7 for 3 to 4 days, and you should be able to do your routine there because the facility is made in such a way. So why do we need all these things? When you want to characterize, now this is little a higher level investigation. So you want to characterize your, are you really having a epilepsy? Second, what kind of epilepsy you are having? What is your EEG in sleep, deep sleep, light sleep, awake state, eyes open, eyes closed? So this kind of data you will need to characterize which syndrome you are having, or where exactly the seizures in your brain might be coming from. At the same time, you will be asked to reduce your medicines so that we provoke you to have seizures when you are admitted in video EEG facility. Your drugs are reduced because we want to study in detail how your seizure looks like, meaning which hand goes first, either a leg goes first or a mouth goes, because this is very important to understand which area of your brain these seizures are originating from, and what is the quality of seizure, are they same every time, because these are the essential things to know or to diagnose which area of your brain is throwing these seizures. And then second investigation, once this is done, the next thing which we would like to do is a high resolution MRI, magnetic resonance imaging, or you might be aware of. So it is not a routine MRI which you get everywhere with a diagnosis of epilepsy. This is a special MRI which is based on the findings of video EEG, and we will focus on that area only where your seizures are most likely to come from, and with a very high index of suspicion that you have to have some kind of problem there. Why I am stressing, because the structural abnormalities causing epilepsy are very subtle in nature, and they are normally missed on the routine MRIs which are done outside. So if you ask me my experience, 30% of the patients which come to us and we operate upon them will come with a negative MRI report, meaning a normal MRI report to come up to start with. So that is the reason we have to get a very focused spatial epilepsy protocol MRI after your video EEG investigation. And the third part is PET scan. So we generally acquire PET scan again during the same hospitalization to get more information about the glucose utilization by your brain. Why it is important? Because the areas which are supposed to have epilepsy coming from are supposed to be low in glucose utilization. Now, why do we need all these data sets? Because epilepsy evaluation is a complex decision to make. So we need 3 or 4 data sets. So one video EEG where we have an electrical data set and your clinical data set, meaning which hand goes first and all that stuff. So that is a one data set to focus on one part of your brain. Secondly, by MRI, we again check if the same part of your brain has some abnormalities. Again, with a third data set or a third type of investigation like a PET scan, we again check whether PET is also showing the same abnormality in the same area of the brain which the other two, video EEG and MRI, is showing. And one more examination is there that is called as neuropsychological examination. Again, a fourth way of looking at the brain abnormality. So we actually need to do 4 data sets converge on the same area of brain producing your seizures. And that is why this is a complex kind of evaluation and needs a long time. It's 4 days.
So if I understand it in a simple terms, it means as a specialist epilepsy surgeon or a doctor collects 4 set of data points to be very sure where the problem in the brain is, right? That's what you are trying to do. Collect different data points from different methods and be very sure that this is the area of a brain where there could be some problem because of which epilepsy is emerging, right?
Yes, you're right.
Great. So once a doctor has identified the area of the brain from where the epilepsy is emerging, what would be the next steps?
Once the diagnosis of drug-resistant epilepsy is confirmed, we are looking at something in your some structural abnormality in your brain, and all these investigations are actually focused towards identifying that area. So with the video EEG, MRI, PET and neuropsychology, we have zeroed down one area and labeled that this is the cause of the current epilepsy. Now the next question to answer is, can we remove that focus without producing any neurological deficits, meaning any problem to the patient, and cures the epilepsy? Because once you find out the structural abnormality, if you can remove it, your epilepsy will go away in 90% of the cases, and you will be all off the drug. And there is a good chance that you will be off the drug also. So the very purpose of pre-surgical evaluation or evaluation of a drug-resistant epilepsy is to understand the focus, or is to zero down the focus which is responsible for epilepsy. Once that is done, and the answer of second question is also positive, meaning we can remove this area without producing any new problem to the patient, then the next line of treatment would be surgery. Once you do surgery and take out that area, there is less than 1% chance of any new deficit or any new problem to the patient, and the seizures will go away in 90% of the patients. So that's the kind of line of treatment, or that's the direction which we take after this pre-surgical evaluation.
And what are the chances of that this surgery, which is done where the area of the brain from where the epilepsy was originating, or it was a cause of epilepsy, what's the success rate of this kind of surgery?
So if the surgery has a 90% chance, 9 out of 10 people will get rid of epilepsy completely. So 90% chance that patient will never have the seizure again, and a 50% chance that patient may not have to take medicines also. Meaning, like if you consider a cohort or a group of 100 people with a drug-resistant epilepsy and we perform them on surgery on them, so 90 people will be seizure-free, but 50 people will be seizure-free and drug-free also. They are not taking any more drugs. So they are kind of cured of all this epilepsy thing. But another 40 people might have to take a single drug in a minimal dose than their previous 3 to 4 drugs which they used to take before surgery. So they might have to take one drug in a minimal dose for a long time, like 5 to 7 years, 8 years, or even maybe for a life. But this one drug in a minimal dose do not have any problem or do not have any side effect profile compared to 3 to 4 drugs they used to take before surgery. So when we talk about the success rate of surgery, it is 90%. 90% of the people will not have the seizure again. But if you ask me complete cure, the chances is only 50% drug free and seizure free. 50% seizure free, but on a minimal medication, 90%.
Now, that's a very a significant percentage in terms of cure, because as you said, right, 50% would be totally free, and another 40% with a help of some drug, they would be free of seizures. Now that's great. What in the other 10% of cases where the cure is not happening, or the patient has not responded the way the doctor tried for, what happens in those 10% of cases?
So unfortunately, this is still not a perfect science. So with all these 4 data sets even converging on a one point and we operate them, 10% of the people fail and they continue to have seizure. So they may continue to have a same seizure frequency or a reduced seizure frequency, whatever, but they continue to have seizure and we call them failures. And they will have to unfortunately continue drugs for years together, because there is no other way to control the epilepsy.
And for the 90% of success cases, the surgery does not impact any other area of their brain, right? And they get into there is no side effect or impact in their other capabilities.
Ideally, epilepsy surgery is supposed to be a quality of life surgery. What we typically call, we are not saving someone's life by doing epilepsy surgery. We are improving his quality of life. And by definition of a quality of life surgery, patient should not have new onset deficits. What is the fun if I cure his epilepsy and give him a complete loss of one limb or something? It doesn't make sense. So, by definition, epilepsy surgeries are safe surgeries. Epilepsy surgeries are productive surgeries. And unless explained otherwise, the chances of getting new deficits after a planned epilepsy surgery is less than 1%, meaning 1 in 100 might develop something or the other, but 99% it is the safe surgery.
Now that's really wonderful to hear that not more than, in fact, 99% of cases, the quality of life improves after the epilepsy surgery. So that's something very wonderful to know, and for patients that's a huge confidence in the process of epilepsy treatment, right?
Yeah. It is a highly rewarding surgery. I will say that this surgical treatment of epilepsy is highly rewarding. There is no other way to treat drug resistant epilepsy apart from surgery, and thankfully surgeries are safe and highly effective. 80-90% effective efficacy of surgery in controlling seizures.
Thank you, doctor. It was pleasure talking to you. Dear listeners, with this we come to end of this episode. Thank you for listening. Please share the podcast with your friends and don't forget to rate and review it. Cheers till we meet next time.